and welcome to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Seedra, and today I'm joined by Farah to talk teeth. Farah, are you ready?
Let's do this. We're covering all things dental today: plaque, cavities, gum disease, cysts, and even tumors that can show up in the jaw.
Before we go full pathology mode, I feel like we need a quick refresher. How do we name and number teeth in the first place? Because personally, I always get confused when dentists start rattling off numbers.
Totally fair. So we've got 32 permanent teeth, split into 4 quadrants: upper right, upper left, and lower right. In each quadrant, we count from the midline outward. First come the central incisors, tooth number 1 in each quadrant, then lateral incisors, followed by canines, then 2 premolars, and finally 3 molars. That includes the wisdom tooth as the last one.
That makes so much more sense now. So 1 to 8 is just counting from front to back?
Exactly. And now let's get into the tooth anatomy. So the tooth is divided into 2 main parts: the crown, which is the visible part above the gum line, and the root, which anchors the tooth to the jawbone.
And starting from the outside in, we've got the enamel, right?
Yep, the white outer layer is enamel, produced by emaloblasts, and it's the hardest tissue in the body. It is made by cells called emaloblasts, and here's the cool part. Once enamel formation is complete and the tooth erupts, those emaloblasts undergo apoptosis. They die off.
Whoa, that's why enamel doesn't regenerate?
Exactly. Underneath that is dentin, which is laid down by odontoblasts. These guys secrete organic matrix, mainly collagen, and start the mineralization process. Their processes extend into the dentin through tiny tubules, and they bring nerve fibers with them. So yeah, that's why dentin exposure hurts.
That explains tooth sensitivity so well. What about the center of the tooth?
That's the pulp, and it's formed from the mesenchymal cells inside the dental papilla. It contains blood vessels, nerves, and the rest of the living tissue of the tooth. The root canal is just the narrow tunnel that the pulp travels through down the root.
And what about the stuff around the root?
Good question. The root is covered by cementum, which helps anchor the tooth via periodontal ligament. That ligament connects the tooth to the alveolar bone, and everything is supported by a solid blood and nerve supply coming from below.
And let's not forget the gingiva, or gum tissue, that protects everything at the surface.
Exactly. When that gingiva gets inflamed or recedes, that's when the problem, like gingivitis and periodontitis, starts to kick in.
Okay, now I feel like we're ready to tackle what can go wrong. Alright, Farah, let's start with the basics. You've got a teenager who says that he skips brushing sometimes, and you spot this sticky yellow layer on his teeth, with the gums just starting to get red and irritated. What's going on here?
Classic case of dental plaque buildup. It may not sound dramatic, but that sticky layer is where pretty much all dental diseases begin.
So, what exactly is plaque?
Bacteria love sugars, so they feed on them, forming a biofilm on the surface of your tooth made up of bacteria, salivary proteins, and dead epithelial cells.
And if you leave that plaque alone?
It mineralizes into calculus, or tartar. That makes it even harder to remove, and worse, it creates the perfect home for anaerobic bacteria. It can either be supragingival calculus, which forms above the gum line, or subgingival below it.
Alright, next up, we've got a 28-year-old who says that his tooth has been getting sensitive to cold drinks lately. You take a look and there's a little brown spot on one of his molars. Any ideas, Farah?
Sounds like a classic case of dental caries, aka cavities. But what's important is knowing how deep the damage has gone.
But how does something like this even start?
It all begins with bacteria in plaque, fermenting sugars, which produces acid. That acid then demineralizes the enamel.
Makes sense, and caries are super common, right?
Huge. It's one of the most common diseases worldwide, and the number 1 cause of tooth loss before 35, especially in people who eat a lot of refined carbs or have dry mouth or poor brushing habits. But here's something interesting. In developed countries, the rates have gone way down thanks to better oral hygiene and fluoridated drinking water.
Okay, walk me through the stages. What comes first?
Stage 1 is enamel caries. That's just localized demineralization of the enamel, and it's often totally painless, so people don't even know it's happening.
And if nothing's done?
Then it progresses to dentin caries. Dentin is softer than enamel, and this is where you start getting sensitivity, especially to cold, heat, or sweets.
Oof, so that's when most people finally call their dentist, huh?
Exactly, but If it still isn't treated, bacteria can reach the pulp of the tooth. That causes pulpitis, which is inflammation of the pulp, and that's when the pain really kicks in.
Like throbbing, can't sleep kind of pain?
Yep, very intense. And if even that is ignored, the infection can spread beyond the tooth and cause a periapical abscess. That's when the infection reaches the bone around the tooth root.
So that's going from I feel nothing to I need antibiotics and maybe surgery pretty fast.
Exactly. That's why catching caries early on makes a huge difference.
So enamel caries, painless. Dentin caries, sensitivity. Pulpitis, pain. Absence, swelling.
Perfect summary, and clinically, you'll often see discoloration, a visible pit or cavity, or in late stages, even swelling and tenderness near the root.
Okay, on to our next case. Let's say you've got a teen with red, puffy gums that bleed every time they brush. You also notice the gums look kinda overgrown. What are you thinking?
Sounds like gingivitis and possibly gingival hypertrophy too.
Exactly. Gingivitis is gum inflammation caused by bacterial toxins, right? And hypertrophy is?
Overgrowth of the gums. Gingivitis comes first, triggered by plaque. Chronic cases can lead to hypertrophy, especially if other risk factors are involved.
Ooh, what kind of risk factors?
Aside from plaque buildup, certain drugs like phenytoin, immunosuppressants, and calcium channel blockers, even pregnancy hormones can cause it.
So, if a patient says that their gums bleed while brushing,
Think gingivitis, especially if there's also bad breath or visible swelling.
but can this be reversed?
Yes, it's totally reversible with proper brushing and flossing, but if calculus has already formed, they'll need professional cleaning.
All right, listeners, one more case before we take a practice question. A 50-year-old patient shows up with loose teeth, deep gum pockets, and even pus near a molar. The gums have receded a lot. What's the diagnosis?
I know this one. This is periodontitis, which is what happens when gingivitis goes from bad to worse.
Precisely. Can you tell us more about it?
It's a chronic inflammatory condition that destroys the ligament, cementum, and alveolar bone holding the teeth in place, leading to tooth mobility and even tooth loss.
And besides loose teeth,
Watch for receding gums, deep periodontal pockets, and sometimes pus. And don't forget, periodontitis can lead to serious systemic issues like infective endocarditis or even brain or lung abscesses.
that definitely does not sound fun. What makes someone prone to this?
Untreated gingivitis with altered oral flora, especially anaerobic gram-negative bacteria. It's also worse in people with immunodeficiencies.
All right, here's a quick challenge for our listeners. Are you guys ready? A 15-year-old patient presents with enlarged fibrotic gums that bleed occasionally during brushing. He has a history of epilepsy and recently started a new medication. There is visible plaque buildup as well. Which of the following medications is most likely contributing to this condition? A. Lisinopril, B. Phenytoin, C. Metformin, or D. Amoxicillin?
And the correct answer is B, phenytoin. Phenytoin-induced gingival hypertrophy is a well-known side effect, especially in the presence of poor oral hygiene.
Yes, other drugs that can cause this include calcium channel blockers. Okay, before we dive into specific cysts, let's take a second to talk about where these things actually come from.
Unlike the rest of the skeleton, epithelial-lined cysts are actually quite common in the jaw, and most of them come from the remnants of odontogenic epithelium. So basically, leftover bits from when the teeth were forming.
And how can we classify them?
They're generally grouped into two big categories based on their cause: inflammatory cysts, like radicular cyst, and developmental cysts, like the dentigerous cyst and the odontogenic keratocyst.
All right, cool. Let's tackle those now. So, Farah, say I've got a 40-something patient who has had a bad cavity for years. They never got a root canal, and now they're swelling near the root of the tooth. We take a radiograph, and boom, there's this neat little radiolucent circle at the apex. What does that sound like to you?
That's a textbook radicular cyst, also called periapical cyst. It's actually the most common jaw cyst.
And this one's inflammatory, right?
Exactly, it forms in response to chronic inflammation, usually from pulpitis, following caries or trauma. And the thing is, the inflammation persists because you've still got bacteria or some other irritant hanging around.
And how common is this in dental practice?
Very. It's most often seen in adults between 30 and 60.
I see. And how does it show up on imaging?
Well, you'll see a well-defined unilocular radiolucency surrounding the root apex. It's often painless unless it gets secondarily infected. And fun fact, some people used to call it a periapical granuloma, but that's not really accurate because it's a true cyst.
All right, Farah. Next up, we've got a 25-year-old man with impacted third molar. He's got mild jaw discomfort, but no major pain. Imaging shows a unilocular radiolucency around the crown of that unerupted tooth. What are we looking at?
Is this a case of dentigerous cyst?
Exactly, which is also known as a follicular cyst. So, what's actually going wrong there?
So, as the tooth is trying to erupt, fluid builds up between the developing tooth and the dental follicle. That pressure expands and forms a cyst.
Yikes. When do these usually show up?
They are most common between the second and fourth decades, and they tend to show up more in males.
And what would give it away on imaging?
You'd see a unilocular radiolucency that completely surrounds the crown of the unerupted tooth. Histologically, it's lined by a thin stratified squamous epithelium and has fibrous connective tissue underneath.
I see. So, how do we treat dentigerous cysts?
With complete surgical excision. Don't worry, they don't tend to recur unless the removal is incomplete.
Okay, Farah, let's discuss the last type of cyst. Imagine this. A 30-year-old patient shows up with some jaw swelling. He says it's been there before and came back. On imaging, there's a multilocular radiolucency in the posterior mandible. What are we dealing with?
That's likely a odontogenic keratocyst, or OKC. And the fact that it's come back, that's a big clue. It's known for recurrence.
Whoa, Farah, you do know your cysts well. Tell us more about this one.
OKC is a developmental odontogenic cyst, and it's got some unique behavior. It's aggressive and has a high tendency to come back. That's why some even classify it as a tumor, specifically a keratocystic odontogenic tumor.
Oh, wow, that is a serious one. When do these usually show up?
Typically between ages 10 to 40, and most commonly in the posterior mandible.
A silly way I like to remember this is that when you eat carrots, you use your back teeth. And keratocysts sound like carrots. So keratocysts are in the posterior mandible.
Ooh, I like that.
And what's going on histologically?
The cyst is lined by a thin, keratinized, stratified squamous epithelium. It has a prominent basal cell layer and a corrugated epithelial surface, which is that wavy appearance you'd see under the microscope.
I see. Now let's talk imaging. What does it look like?
So it can either be unilocular or multilocular, but it's always well defined. And as I mentioned before, they grow aggressively and recurrence is a big issue, especially if the excision wasn't complete.
Oh, right. Isn't there sometimes a link between OKCs and skin finding?
Good catch. OKC may be associated with multiple basal cell carcinomas, so if you see more than one, you should definitely consider a broader systemic link.
All right, listeners, time for a quick review challenge. A 27-year-old man undergoes dental imaging for an impacted third molar. A unilocular radiolucency is found surrounding the crown of the unerupted tooth. Histology shows thin stratified squamous epithelium lining a fibrous wall. What's most likely the diagnosis? A. Radicular cyst. B. Odontogenic keratocyst. C. Dentigerous cysts. Or D. Ameloblastoma.
And the answer is C, dentigerous cyst. This cyst forms around the crown of an unerupted tooth, often a molar, and is lined by a thin stratified squamous epithelium. Key imaging clue, that unilocular radiolucency hugging the crown.
Okay, Farah, we've covered cysts. But now we're moving on to the odontogenic tumors.
Right, these are true neoplasms that arise from components of the tooth-forming apparatus, like epithelium, mesenchyme, or both.
And they're not all aggressive, right?
Exactly. Some are slow-growing and benign, while others can be locally invasive. We'll talk about two examples today. Odontoma, the most common odontogenic tumor, and the ameloblastoma, the second most common. Let's get right into it.
Okay, Farah, let's say you've got a teenager who comes in for delayed tooth eruption. Imaging shows a hard mass near the jaw that does not look like a regular tooth. What are we thinking?
That's most likely an odontoma. It is associated with extensive enamel and dentin deposition, but here's the twist. It probably isn't a true neoplasm.
Exactly. which is why most odontomas are considered hamartomas. So, what's the management for these?
Pretty straightforward, just a local excision. They're benign, and removing them usually solves the problem.
Okay, Farah, last one for this episode. Let's see if you catch this one. Picture a 40-year-old with a slow-growing swelling in the lower jaw. It's painless, but imaging shows a cystic lesion expanding the mandible. What are we likely looking at?
That's a classic presentation of ameloblastoma. It arises from remnants of the enamel organ. As you said, it's slow-growing, usually develops in the lower jaw. And although it's benign, it's locally invasive and has a real tendency to recur if not fully removed.
Exactly. Now, what would we see under the microscope?
You'll find a cystic lesion lined by palisading epithelium, which kind of looks like a piano. That's the classical microscopic feature.
So we can remember this by saying Amelia plays the piano for ameloblastomas having palisading epithelium. So how do we treat it to make sure that it does not come back?
With wide surgical resection. Beware, anything less has a high risk of recurrence.
Okay, Farah, before we sign off, let's do a quick recap for our listeners. What stood out most to you from today's episode?
Honestly, just how much trouble that little layer of dental plaque can cause. It seems innocent, but it sets off a whole chain of issues, from caries to gingivitis and eventually periodontitis.
Honestly, me too. I liked how you broke down the progression of caries, starting with painless enamel damage, moving on to dentin sensitivity, and then full-blown pulpitis. And if left untreated, even a periapical abscess.
Right. And while gingivitis is still reversible, things get serious with periodontitis because that's where you start losing the actual structures that hold your teeth in.
Then we got into the world of odontogenic cysts. And honestly, I was surprised by how different they are depending on whether they're inflammatory or developmental.
Exactly. Radicular cysts come from chronic pulp inflammation, while dentigerous cysts come from unerupted tooth crowns and OKCs. They're their own beast, aggressive, recurrent, and sometimes linked with multiple basal cell carcinomas.
And finally, the tumors. Odontoma is the most common, but more of a hamartoma, really, and all that enamel and dentin buildup.
And then ameloblastoma, which was the most serious one we talked about. Slow growing, but locally invasive, and you really have to take it out with wide resection, or it'll come right back.
So, moral of the story? Brush, floss, and respect your dental anatomy. And that officially wraps up our deep dive into dental diseases. From plaque to pulp, cysts to tumors. We really covered the full arch today.
It's always wild how much pathology can come from such a small space, but once you understand the patterns, it all clicks.
Totally agree. And if this episode helped clarify things, we'd love for you to share it with a friend. Or play it again during your next study session, maybe?
Keep brushing up on the basics, pun fully intended.
And we'll catch you next time on PodBites, where we keep pathology painless.